please start.
Yes, sir. Dear members, I am Dr. Shivkumar, Joint Secretary at Medical Service Center, Karnataka. So I'll be moderating this session along with Dr. Vasudendra, who is the Secretary of Medical Service Center, Karnataka. He'll be joining the second half of the session. A warm welcome to all of you. MSc wishes all on occasion of Doctor's Day. This year also happens to be the death centenary year of the legendary physician of our medical profession, Sir William Osler, whose aphorisms, commonly known as Oslerism, are well known among the medical professionals. So in order to remember this great medical personality and his contributions to the field of medicine, Medical Service Center Karnataka is organizing this online discussion on this topic, Declining Art of Clinical Medicine. The art of medicine is as important as the science of medicine. Has there been declining in the art of medical practice over years is the concern and the question that is roaming in minds of many medical professionals across the years. So hence to talk on this important topic and also the thoughts of Osler and Oslerism, today we have with us Dr. Lakshman K, who finished his MBBS from the prestigious Bangalore Medical College in the year 1976. Later, he pursued his degrees LRCP, MRCS, FRCS from the prestigious universities of the London, and also fellowship in surgical metabolism and nutrition from Harvard University in the year 1984. Sir is now working as a consultant laparoscopic and gastrointestinal surgeon practicing in Bangalore. And Sir had been the faculty in surgical gastroenterology for RGOHS, and he is associate editor in Indian Journal of Surgery. So we thank him for accepting our proposal and being part of this meeting. We felt he's the right person to conduct this program. Now we request all the participants to put their questions in the chat box. Those questions will be taken up by the sir after completing his presentation. If time permits, in the end, the audience might place their opinions. So we request all the participants to not unmute their mic and to switch off the video and not to switch on the video in between. So we need your full cooperation for fruitful conduction of this session. Now I hand over the session to Lakshman sir. Over to you, sir.
Shivkumar, thank you very much. A very good evening to all of you, and a happy Doctor's Day greetings. My apologies for the little hitch in the beginning where the connection between the Zoom meeting and the live YouTube streaming gave us some trouble. It is very apt that on the occasion of the Doctor's Day, we think about William Osler. I think he's one of the best known physicians who was to be revered and be honored by the whole medical profession and society at large, basically because of his tremendous human values. He was also a prolific writer who gave a lot of extremely attractive and extremely quotable quotes. So what I plan to do in the next 35 minutes or so is to share a bit about Osler's life amongst ourselves and talk about the art of clinical medicine and see how that gels with the scientific basis of medicine. Science is very important, and so how does it gel with the science behind medicine? And what is it that's happening in society that may positively or negatively be impacting on both these issues, the art and the science of medicine? And just say a few words. There are no easy solutions or easy fixes to anything in the world. So is it with these issues that we have. And so just share a few thoughts about what we can do to find solutions for these issues. William Osler was born in northern Canada. His father was an Anglican priest who emigrated to Canada from Cornwall. And it seems to me that from his childhood, he had a kind of attraction to philosophical issues, not just medicine. And he was always in the present. He was a very practical person, even though he was very philosophical. He had the background of divinity in the form of a priest as a father. He was very rooted to reality and the present, two issues which are very important for doctors in general. He actually enrolled into a course into divinity in Toronto, Trinity College, Toronto, but a year later moved on to medicine because he found it more interesting. And he seems to have come under the influence of two very strong or very powerful teachers, Bobble and Howard, who taught him what he called unrehearsed humanism. And that is, I think, the key to the whole issue of medical care or patient care. Humanism is defined as a rationalist outlook or a system of thought attaching prime importance to human endeavor, human intervention, rather than something divine and supernatural. So what it essentially means that as a doctor, you do the best you can and not to worry too much about divinity or supernatural matters. He spent a few years in Europe, which had a profound influence on his learning. Please remember, at that stage, Europe was the center of medicine. All progressive thoughts in medical and surgical care came from Europe at that stage. And he was also a very active writer and an administrator. He had a lot of important role to play in the Canadian Medical Association. He then moved on to Johns Hopkins in Baltimore, and it is nice to know that he rubbed shoulders, and it was the same time as Halsted and Welch, two giants in the field of surgery. He married a widow when he was 42 and moved to Oxford from America in 1904 as a Regius Professor of Medicine. Unfortunately, lost his only son. He had two children. The elder one died at a very young age of a few months, I think. But the younger son grew up to be an adult, but he lost him in the war of 1917, the World War, the First World War, and he himself died 2 years later. He was known for his clinical teaching, particularly bedside clinics. As we know it today, Osler is the originator, one of the originators of the bedside clinics as we know it today. And at every one of his teaching sessions, he made it a point to tell his students to have a close contact with his patients. And when we see some of the quotes that I'm going to show you and some which you have seen in the introductory video, you will see that he was perhaps the first person who vocalized the concept of holistic care of a patient. And when he was talking about the philosophy of care, he never forgot about science. For Osler, science at the expense of art was wrong. Both needed to be there, not just one or the other. He was one of the biggest advocates of being scientific in your outlook, but at the same time bringing in humanistic patient care. I'll start with a couple of stories, true stories. We need not know where it happened or who the doctors involved were, but it has a lot of contextual meaning to what discussions we're going to have subsequently. It is important to know that when you talk about patient care, humanistic care, and clinical medicine, essentially ethical principles are intertwined with it very, very closely. So we are looking also at the same time talking about medical ethics as we are talking about clinical medicine. Here is a patient, 58-year-old, multiple trauma, head injury, multiple broken bones. Average means, that is important because the financial aspects of care always come into the equation when we look at patient care. Had his extradural, the blood clot in the brain drained, had his fractured bones fixed. Never really woke up very well, but as it happens, a few days later, in spite of all the care, he became a little septic, he dropped his blood pressure, had to have 3 or 4 medicines just to keep his blood pressure up. When this happens, we all know that it can affect the blood supply to the intestine. And there is not enough circulation. These medicines keep the brain and the heart alive, but they direct the blood away from the bowel. And the bill keeps mounting in an ICU. It's always a very expensive care. And in fact, we knew that the family had to sell some land to continue his medical care. And somewhere down the line, a few days down the line, this gentleman developed an abdominal distension. The abdomen bloated. There was something wrong with the abdomen. A CT which was done even before a surgical consult showed a possible perforation or a hole in the intestine, which can be a fatal thing. And so a surgeon was called, and the surgeon looked at the whole thing and said, please, it's very unlikely that we're going to make him better with this. Any active intervention is futile, so leave him alone. Okay. Please note what I have written on the. No one is bad in this story, and no one is wrong. Everybody is trying to do his best to the patient, but Surgeon A's opinion was that he should be left alone. The family wanted another opinion. So another surgeon from the same institution was called. He was a very nice person himself. He actually consulted with Surgeon A and told Surgeon A, it's a lot of pressure on me to do something. What should I do? So the Surgeon A told Surgeon B, you have to take a call. My call is that we should not do anything. So Surgeon B took a call, very considered call, and operated on the patient and found that a lot of his blood bowel was dead because of ischemia, because of lack of blood supply. He did what he could to the patient, but the patient died 2 days later. Should he have been operated? Should he not have been operated? Is the question. There are no easy answers. Please bear this in mind. I'm not trying to be judgmental here. None of us can be. But just remember that this is one extreme where a patient's life is involved. You come to another very simple situation. There's a lady who has a classical pain, abdominal pain, suggestive of a stone in the gallbladder. You take a test, it shows a stone in the gallbladder. Patient herself believes that she has acidity, she has an ulcer. Surgeon says, look, your symptoms are suggestive of a stone, not necessarily that of an ulcer. But she insists on having an endoscopy to know whether there is an ulcer or not. And the surgeon does it on the patient's request. Mind you, while it may not be very expensive, it will cost 3,000 or 3,500 rupees to the patient's bill. It was done on the request, even though the surgeon knew that it probably was not an ulcer. The question is, should he have done it, or should he put foot down and say, look, I'm the professional here. I do not think you have an ulcer. I do not want to do an endoscopy. Go elsewhere if you want. Is that the way approach? Is that the approach? Or should he do it just to keep the patient happy? As I said, clinical medicine, while we may claim that doctors are not following it, they're trying to be too technical, is not based only on the doctor. It is an interaction between the doctor and the patient, and a joint decision is made. And one of the things that come in the way of pure clinical medicine is the societal attitude. That's what I'm going to talk about at the latter part of my presentation. By definition, clinical medicine is a study and practice of medicine that is founded on the direct observation of the patient. Now, it includes a history, a clinical examination, you examine the patient, basic tools, and remember this, no tests. Now, this basic tools is a very, very dicey situation. Is stethoscope a basic tool? Is a blood pressure apparatus a basic tool? We do that. Today, we have handheld Dopplers, ultrasound machines, which can be hooked on to your phone. You can use an ultrasound examination hooked on to your phone and get an information on the patient. Is that a basic tool? It could be in the future. So please understand that there is a gray area when we call something a basic tool. But for a working knowledge, as of now, I think a simple stethoscope, a blood pressure apparatus, and things like that would come under our basic tool. Obviously, for Osler, that was what was available during his time. This business of CT scans, MRIs, ultrasounds, things like that were not available in his time. And so you can see he defined the fine art of clinical medicine as best as one could. Observe, record, tabulate, communicate, and use all your senses. Now that holds true even today, even though the attraction that the ultrasound or the CT will tell you something much more than what all these senses tell us will perhaps make us skip this part of the examination. But we should not forget that this is what we start with. Use your senses first to see the patient, understand the patient, and then go on to the next part, which is the investigation. And this has relevance. We need to know everything about the patient, not just about the disease. Let us remember that we are treating the patient and not just the disease alone. So science comes in. Science has come in, it will stay, and it has to stay. But what is science? Please remember the date here. The date is 1853. Ruskin defined science as work which involves substitution of facts for appearances and demonstrations for impressions. This is a very loaded statement. We see something, we have some kind of an appearance or an impression, but you've got to prove that that impression is correct with hard, solid data. And that is very important for things that we do. Now, if you look at the confusion that we are having in the present pandemic, it's very clear. One day you're told wear a mask, another day say it's not important. One day you're told you do this, the next day it is changed. One day you're told HCQ is important, another day you're told it's not. Why is it? Because science and demonstration of facts takes time. It takes time. And so you need to give that time. And in the pandemic, you may not have the time. And so people try to take shortcuts and in that process end up with trouble. And of course, this business of EBM, evidence-based medical practice, has come into being from the mid-90s. Please note, while I'm not talking about EBM at length here, you need to have science, which is best external evidence. The person who practices must have the expertise that is doctor-related. But please remember, the third arm of EBM is this: patient values and expectations. He has an equal part. And this Venn diagram shows you that where these three things overlap, when all three things are considered together, then you are practicing true evidence-based medicine. And that must be the aim of all doctors. So when we talk about science, what Osler said about 100 years ago holds true even today. It is a science of uncertainty and an art of probability. Even today, with the best and the most investigations that we have at our disposal, you will find that there is a degree of uncertainty. You might be 90% right, 95% right, maybe 98% right sometimes, but there is definitely a degree of uncertainty. And the rest of my talk is going to describe this to you and make you understand where our usual problems are. The problems in medicine, the problems in the accuracy of our diagnosis, problems in believing our test results completely lies in these three issues. One of them is the natural phenomenon. There is nothing like, it's not mathematics. Each person is different. So what is normal for one may not be normal for another. There are inherent limitations in the test. The only thing that I can think which comes close to the uncertainty of medicine is that of our meteorological department, our weather forecasters. It is a natural phenomenon. The guys do their best, you know. And when they say you have rain tomorrow evening at 4 o'clock, you will have bright sunshine. We all laugh at them, take a dig. But please understand, they're dealing with inherent limitations in the tools that they have. And honestly, a doctor is not too far away from that. And also, diseases are ever evolving. The same disease is not the same. No, diabetes is evolving. Infectious diseases are evolving. Coronary heart disease is evolving. What was true of diabetes 30 years ago is not true today. So we are actually dealing with a moving goalpost. We are trying to catch up with something that's happening. All doctors in all fields, they're doing this. And so there is a limitation to that. These are the three main things that we have to bear in mind. And one of the things that I mentioned about natural phenomena is this phenomenon of what is called the Gaussian curve. This is called a Gaussian curve, where there is a range for each person or each group that is normal. You may have a mean that is the middle, and up to 2 standard deviations away from the mean cover 95% of the population. It doesn't cover 100%. So when you say something is abnormal in a given population, that should be more than 2 standard deviations from the mean. But please understand that is true of 95% of the population. In 5% of the population, even that value or that not so-called abnormal thing, which is 2 SDs, standard deviations away from the mean, will still be normal. These are called outliers. Outliers are a natural phenomenon which is normal. That's what puts that uncertainty in medicine. And tests that we do always have a concept of false positive and false negative. So let me spend 5 minutes explaining what this is. Now, a false negative test is a test that indicates that the person does not have a disease or a condition when the person actually have it. For example, if you want to know the truth about the COVID test, COVID PCR, which is supposed to be very good, PCRs are supposed to be very good tests. Up to 15 to 20% of those tests that we give can be false negative, which means that when the patient has, when you do the COVID PCR on 100 patients, suppose it says all the 100 patients are COVID negative, 15 people among those can still be positive. That is the absolute truth about as straightforward a test as a COVID PCR. It may be scary, but one needn't be scary, needn't be scared about it, because all of tests are like that. There is a degree, if not 15, it may be 5, it may be 2, it may be 10, but there is a degree of false negative rate. Here is a true story again. Patient with a lump in the neck. We always, when we think about it, we think of a possibility of a cancer or a tuberculosis. We took that lump out and sent it for a test. And please note, the two opinions said that it was tuberculosis. We gave them treatment, patient didn't get better, which again means it must be something other than that. So the fourth opinion later confirmed that the disease was in fact not tuberculosis, but a combination of tuberculosis and cancer. Obviously, the patient doesn't understand this nuance of false negative, and then the patient was sued. And of course, the matter is sub judice, but the point is that that uncertainty had nothing to do with what the doctor was doing. Operability assessment is something which we again look at. CT scan is something that is done very commonly. We do that to know whether a tumor which is sitting wherever in the body can be taken out or not. We are supposed to know through the CT scan if it has spread very much and you are not able to operate. So we had a situation where a surgeon had done a CT which had suggested that it was operable. So he goes into the patient and he sees that it is not operable. It cannot be taken out. It has spread well beyond what the CT scan had suggested. And so he calls another surgeon and says, look, I have this problem. What do you think? Is it really operable? Am I missing something? The second surgeon goes and then says, no, I think you're right. You cannot operate on this. And then we close the abdomen without operating. And then do something else. Try to do something else. But the patient went away elsewhere and somebody did operate with unfortunate consequences. This is the kind of thing that can happen where you cannot believe the reports completely. Just the opposite is this concept of false positive result, which indicates that a person has a specific disease or condition when the person actually does not have it. That is also equally bad, perhaps even more bad, because you're labeling the patient with a disease when he actually doesn't have that disease. This happens very, very commonly. This patient had a condition which suggested there was something wrong with the pelvis, which is the lowermost part of the abdomen. And a CT scan was again done and it showed a lump in the area. So the surgeon went in to try to take the lump out and finds that there is no mass, there is no lump. Very surprising, but true. Then we had to come out, the patient had to come out and tell the person that, sorry, there was no mass and that we did everything. And of course, you take photographs and things to prove that there is no mass. Similarly, something very commonly done, breast cancer screening done in many countries, including our country. The hard facts of this, over the years, over 3 to 4 decades, people have proven that people dying of cancer have the mortality or death from cancer has been reduced by 40%, which is very good, very nice. But in a mammogram, this is good for a population of thousands of people or millions of people. But in a given patient, when you have a mammogram, there is a 10% chance that you have a false positive case. So it tells you that there is a cancer when it is not. Look at the impact, the tremendous emotional impact on the person. where she is told that there is a cancer when there isn't one. And even more important, 15 to 20% have false negatives, which means up to 20% of people, when there is a cancer, the mammogram doesn't pick it up. So this is the truth. But what does our average patient think? When they go for a mammogram, they'll think that, well, I know what's happening. It tells me whether I have this, I don't have it, and they think it is 100% right. Far from it. So when you have a doubt with a mammogram, then we now have a tool called the magnetic resonance imaging, an MRI. So you take an MRI, to see whether somebody has a cancer or not. Then the false positive rate for MRI is 30%, which means that when you have no cancer, the test can suggest that there is a cancer. And of course, when that is suggested, the surgeon will go into other things, maybe even do an operation. And such things are completely unnecessary. But there is nobody is wrong, nobody has any ulterior motive, nobody is inefficient. That is the state of our science and art of medicine. So these are the reason I'm bringing this up is to say that if clinical medicine is extremely important, investigative tools are very important, but if we think that the tools will far outweigh the things that you get from your clinical assessment, one would be making a mistake. The two things have to be gelled and looked at holistically and completely. That is where the decision of the doctor comes into being. This is where the Googles and the internet cannot answer you. They are just looking at facts as they are, and they cannot factor in the overall impression, the overall approach that a doctor can have. And the doctor must develop that habit of having that overall approach and not dismiss investigations as being false, which they are not. There may be some false things, but they are very important for us. And dismiss clinical medicine because he thinks it is not informative enough. That is also wrong. He must work towards gelling the two, getting the two things together and give the best to the patient. That must be the approach of a doctor. What is the social or societal attitudes doing to the whole process? Forever, we are talked about wrong diagnosis. People say you went in with, when there's an emergency situation, there's an abdominal pain. You examine the patient. It's very commonplace for doctors. You say, well, I think you probably have appendicitis. Please get into the hospital. We'll do some tests. You do a few tests, it tells you it's a kidney stone. And the patient turns back and says, look, you don't even know the difference between an appendicitis and a kidney stone. Very commonly it is said, yes, it is possible. Even though you have 30, 40 years of experience, there can be a difficulty in diagnosing any one or the other disease. People forever talked about overdose of medicines, unnecessary tests done to keep machines busy, keep our investigative machines busy, unnecessary operations done just to make money. These are things that are very commonly leveled against doctor. But please understand, if I do pure clinical medicine and then do not get a test and say, look, I don't think this is it, I'm uncertain about my diagnosis. If I send you away and even say I'll postpone the tests, people may take an exception. They may say, I'm sorry, you missed something. You're sued because you missed something because you didn't ask for a test. So what should the doctor do? That is something we have to bear in mind. Unnecessary operations. Nobody wants to just operate. You may say there's a small percentage in every community that may happen, but the large majority of doctors would be making correct decision about what to do. And it may turn out, as I showed you in the examples earlier, that a particular thing that had to be done might not have been possible to be done because of the exacting circumstances. The media is doing nothing to help the process. Instead of bridging the gap between patients and doctors, they've always chosen to dramatize the whole thing. A headline like, are our doctors healers or predators? Because it happened on a TV show. And what does it do to the psyche of society and the psyche of the doctor? The judiciary is doing nothing to help either. Bigger and bigger compensations are awarded. And obviously, the patient will think that, yes, if I sue the doctor, I'll get something out of it. It must be an example. It's called exemplary punishment. It must be an example for the doctor and society of doctors and the group of doctors not to do these things again. I'm not finding fault with that philosophy, that thought. But many times, you should take one step back and think, look, is there really some kind of a negligence that happened or not? So where is it taking us? We're taking us towards defensive medicine. Very common. Across the world, this is happening. Across the world, defensive medicine is happening. What is defensive medicine? A patient comes to you, there's a little cartoon here, but it is not a huge exaggeration. It can still happen even today in a hospital. You can't blame only the doctor for this, because society is equally responsible for pushing him against the wall with all the litigations. If the patient goes with a headache, and here is the doctor saying, look, let me get a PET scan, there is that tonsillectomy, and we'll consider this and that. No, 100 different tests are asked for. What are the downsides of it? It's expensive. It is over-diagnosis. I told you about the use of MRI. I can give you hundreds of similar examples with all other tests. So you will have false positive. If you do more tests, it will show up some disease which is not there. Which may, I'm not saying it will, it may show some disease which is not there. It's neither the doctor's fault nor the machine's fault. It is the state of our science of medicine, which is uncertain. And that's exactly what Osler said 100 years ago. Okay, it is a science of uncertainty and an art of probability. We can't forget that quote. And of course, when you have a diagnosis, when the machine tells you that there's something wrong, the doctor can't sit on it. There will be an unnecessary intervention. Now, is this a hopeless situation where all of us are in a big muddle and we know nothing? Please understand, whatever I said to you now applies to about 5% of our patients. 95% of all the thing that goes on in the medical field still goes on very well. Correct diagnosis is made, correct intervention is made. There is nothing which is wrong. But the 5% that doesn't go well has been exaggerated in society, has been exaggerated in the media, and all our focus is on that 5%. I agree, for a given patient, it is a big disaster. Something like that happens, I agree. But in the overall context, it's only 5% of people who have this kind of a problem. What can be done about it? I think the key to the whole thing is communication. Communication about the fallibility of the doctor, about his limitations, communication about the limitation of the tests, and a process that everybody is seeing being done properly. A detailed history, spend some time, take the story, a full clinical examination, I mentioned about the communication, and above all, reassurance that waiting is okay. If you come with a lump in the neck, they will have known, they will have Googled, or somewhere else, somebody would have told them that it could be a cancer. So it is our job to say that, look, you wait for 2 weeks. It may be a viral disease. It may go away. The lump may go away. Just wait for 2 weeks. And tell them, even if it is a cancer, waiting 2 weeks, nothing happens. Try to reassure them and always have a planned revisit. Get them back to see them clinically about what is happening. You can't discharge them from the clinic and reassure them falsely. Get them back. It is reassuring for them. It is safer for you as a doctor to see them again. And this overcomes this beautiful statement that we as students of medicine are actually courting a fickle mistress. Really, it's a moving post, a goal post, as I keep saying. And so it will elude our grasp, and all of us must be aware of that. And I mentioned about this, beautifully articulated by Osler. Variability is the law of life. Okay, and no two individuals react alike and behave alike under the abnormal conditions which we know as disease. Every one of us doctors has faced this. You see the same disease, same appendicitis, you open the abdomen and see one of them you can take it out in 10 minutes, another one you struggle for an hour and a half and you still can't take it out. Same appendicitis, same disease. But that is the variation. It can give you some difficulties in treating the patient, but it also, I see it as a challenge and an interesting challenge and an intellectual stimulation as a doctor to see that we will try and conquer this variation, try and see what we can do to help the patient. And how do we cope with this? Please understand, we are not talking only from the doctor point of view, but of course my solution is probably doctor-centric because I am a doctor. I don't want to be biased, but willy-nilly, I am a doctor. So what I would recommend to do, and of course I need the inputs of the Honorable House here to discuss this during the discussion period, is to accept our limitations. We can only achieve that much. We are not superhumans. Explain our limitations to the patients. Keep an open mind, invite opinions. If you feel that something that is not something that you expected to happen has not happened and you're not getting the progress that you need in a patient, take other opinions. Be watchful, look at many angles. It's never straightforward in medicine. We have a concept called differential diagnosis. You're working with a working diagnosis. You say something is a given disease, start treating like that. Do not hesitate to change it. Keep an open mind because it could be something else. In fact, diseases are evolving. What looks like appendicitis on day 1, on day 3 may look like something else. And so things evolve and the patients must be told that it is not our ignorance or our stupidity, but the nature of the disease is such that there can be changes. If necessary, repeat tests. Obviously, you will be hauled up for doing that because you're making the patient spend more money. But again, explain to them, and hopefully they understand that things are changing, things are not what it was yesterday or day before. So I'm now looking at it with a fresh angle. And that has to be explained in all sincerity. What about patients? How should they approach this? They should give doctors time and space. Their expectations of what the doctors can do should be realistic. What is happening today is that, look, we come here, you're the professional. We don't care how much money you make us spend on tests. I want answers. I want instant diagnosis and instant cure. That is an unrealistic expectation. No healthcare system, no doctor can meet that expectation. Once that expectation is not met, problems start. The first thing that they do is, look, this doctor is doing some hanky-panky. He is doing something which is not right. So they shop around. They go to other doctors, other institutions. That leads to more problems and more confusion. And also at the end of the day, this is something which will be a most controversial statement that I'm making today, but I'm making it knowingly that occasionally doctors fail. And failure is not negligence. You know, he didn't stand by the patient, save the patient, or cure the patient, not because he was good, he was not good, or not because he was negligent, because he couldn't. I always believe that doctors are like firefighters. They didn't start the fire. Most of the time, firefighters bring the fire under control, but not all the time. There will be casualties, there will be damage. And so that is what is going to happen in healthcare field also, and that's going to happen forever. I don't think anything will change that for time immemorial. So I thank you, ladies and gentlemen, for your patient listening. I leave you with this beautiful quote from Osler. Thank you again, and I'll stop sharing the screen so that we can have a discussion. Good evening.
Thank you, Lakshman sir. That was an excellent presentation covering almost everything about Oslerism and his life and the dilemma regarding the advanced medicine and the traditional medicine. Now we swiftly move on to the questioning session. Those who have any questions can put up the questions in the chat box, and each question will be taken up by sir. So please don't waste time. Place your questions in the chat box.
Okay, can I keep taking it? I'm looking at the chat box now.
Yes, sir.
First question from Dr. Maulya. Whom to blame for this decline? The explosion of technological innovation or reduction in the quality of great teaching? Honestly, no blame at all. I don't think we should blame anybody for it. We should introspect. And I think every one of us must learn to retrospect and see where we may be missing the script, as we call it. Try to bring a balance, as I had mentioned, and do the best you can. Do you think EBM could completely replace CBM in the near future, clinical-based medicine? Uh, EBM is CBM. I don't think the two are different. As I mentioned earlier, uh, evidence is very, very important. Osler mentioned it in his time, more than 100 years ago. You have to have science, and it will be incorrect to think that clinical-based medicines is not scientific. It is scientific. So you take take a thorough history, do a clinical examination, and choose the right tests, and interpret those tests, bearing in mind the limitations of those tests. That is the fine art of medicine. I hope I answered you there. How do you develop the art of detachment? Not an easy thing to say, I must say, Anant Kamath. Not an easy thing to do, but I think age helps. I think I'm a different person today than I was 25 years ago. Age helps. The way forward, I think I have mentioned enough about the way forward. If there is anything else, at this point, I would like the other doctors here to say a few things and come in and give their comments, please. It's not right that only I do the talking. I would like somebody else to come, and I see Anantram on the screen. Anantram, can you please unmute yourself and say what you have to say about the way forward, please? Thank you for joining.
Hey, thanks. No, I just had a question, and it's a very funny question.
All right.
What's the difference between a doctor and God?
I can't answer that because I don't know what God is.
Oh, really? Okay.
so I really can't answer that.
Okay.
But I can tell you this: doctor is as human as can be, and he can never ever say he's something beyond the patient. He's a professional. He's a professional who is trained to be to do doctoring, and nothing beyond that.
I was taught, and I've grown up in this tradition, that God never thinks he's a doctor. That's the difference between a doctor and God.
All right. All right. Okay.
Okay. That was a good talk, and I think you covered a lot of it with some examples from your own experience. And but I felt somewhere that a lot of it was restricted mostly to, the talk was probably directed to surgeons and not doctors in general.
Okay.
Because, there are so many different specialties and faculties, and probably from the audience who are participating, there would have been people from, a large number of people from different faculties, particularly family physicians who could have. But nevertheless, well done. You come well prepared. There were some glitches in the beginning, notwithstanding, it was a good evening. Thank you very much.
Thank you. Thank you. A question from Anoop. Is this art limited to certain regions, or is it a worldwide phenomenon? Clearly a worldwide phenomenon. There is absolutely no regional bias in the whole process of health care. Patients roam from one doctor to another due to ignorance or confusion. What is the solution? No easy solutions, but there must be trust between the patient and the doctor, and it is a two-way process. The doctor must also endeavor to earn the trust, and I think communication will help in getting that trust. But I've had situations where any amount of communication or any amount of reassurance has not worked, but that is the way life is. Everybody is not the same. Comments on collusion between pharma, drugs, devices, and doctors. Major cause of mistrust of doctors by the public. It exists. I'm not saying it doesn't exist, but I don't think it is rampant as people may make it out to be. And society at large must be aware of this fact and must do its best to stop it. But can you stop it 100%? No, nothing. It's like stopping corruption in India or anywhere else in the world. We must keep working to reduce it, but stopping it completely is, I think, an impossible goal. But that doesn't mean that you should stop trying. I think you should continue to try to stop this collusion.
Sir, excuse me.
Yes, sir.
Yeah, I rejoined. There was some technical problem.
Okay.
You want me to read questions, or you can go like this?
I'm reading the questions myself. I'm fine. But
Okay,
I would
sir.
like you to comment. I
Yeah.
see that others are not giving their comments. When I say something, I'm going to pause after I answer, and I would like others to join in and say what they feel, and they're welcome to have a different view. This is something which all of us in society must discuss. So I would
Sure.
like comments from others to talk about this collusion between the pharma and drug company and doctors.
Dr. Lakshman, this is Nalini Rao.
Yeah.
I had asked a question actually.
Okay.
And I had a major argument with a friend who suggested, and he's a very educated person, who suggested that this was a problem. I was defending doctors. I said what you said, that maybe a few people might be bad, but not all.
Yeah.
But then I spoke to my husband, my daughter, both of whom are doctors,
Yeah.
and their feeling, and my daughter she topped her class in Bangalore Medical College and has now become a management consultant. And
Yeah.
her view, and this is from the outside, is that doctors are corrupt, what she hears. A lot of it, and I mean, even things like a trivial, it could be a pen, it could be a holiday, it could be a conference sponsorship, and it is rampant. So I did do some rethink, and that is one of the reasons for asking this.
Right. Well, it is, where is the evidence for this? I'm not defending doctors. I can very openly tell you that I do not participate in receiving any gift, even a pen from anybody. I have not done it for the last 30 years. But how can you say how many people are doing it? And how can you say paint everybody with the same brush? That is a challenge. That is a challenge, and no easy solutions. If somebody thinks it is rampant, I take the point.
I agree completely, but as a profession, as an association, I think doctors have to address this in a more meaningful way to get the public to trust us more. It's not about clapping hands or shaking. They should have trust in us.
Yes, I agree with that completely.
Lakshman,
Yeah. Yes, sir. Yes, sir. Go on.
Lakshman, I think one of the important aspects in medical practice is the fact of documentation. And I think this has been underlined very clearly. Documentation has got to be proper, complete, legible. And now, if you know, the Supreme Court has instructed that all prescriptions should be written in capitals. That's basically because many of the prescriptions written were illegible or misinterpreted. What I'm stressing is the three facts about documentation. Documentation should be complete, should be proper, accurate, and legible. That's it.
Fair enough. Point taken. Could Dr. Hema please stop sharing the screen, please?
Yeah. Dr. Hema, please. I think by mistake it might have happened.
Yeah. Kindly stop sharing the screen.
Wait, sir. I will just inform her.
Yeah.
Hello.
I did it myself. It's all right. Yeah.
Yes.
Go on.
Hello,
Sir.
Dr. Lakshman and Dr. Anand Kamath here.
Good evening.
Good evening. I feel a part of the whole scene is because there is one commercialization in education. Right from the beginning itself, if you can pay good donations, you get even for LKG, UKG, from there it starts that you can get into a better institution in spite of whatever other things are. And number two, the investigations that have come have been used to the compensate for the shortfall in the art of diagnosis. So to a large extent now, instead of palpating the abdomen and finding a mass or whatever, instead of that, you get a straight away do an ultrasound and see whether there is a splenomegaly or not. So even a mediocre is able to get through into this and try to be equal with a person who is the uh, cut about the rest. So the compensation by virtue of advanced investigations. Now if you can't diagnose, then you, but the art itself cannot be substituted, and the concern for the patient. So that particular issue has to be within, whether it is this person or that person, and it is not restricted to doctors, whether it is in commerce, as a human being. So I
Very
think
true.
we should have human values inculcated. There is only marks are counted for getting into medicine. Whether you really have an aptitude towards it, there is no institution which measures your aptitude. Whether you have humane values, whether you are honoring the patient as a whole.
Yeah.
These aspects are never considered when you choose medicine. Medicine, by virtue of its nature, is a different kind of.
Sir, yes, sir. Yeah, I got your point, sir.
So
I think
Vasudendra, now there are quite a few questions. So may I request you to read them,
Sure, sir.
screen them and put it to me and the audience, sir. Please.
Yeah, I think I will read, like, yeah, one of the questions like I'm seeing now is family physician relevant or not relevant? That is one question.
Okay.
And
actually, I had one question.
yeah, 1 second, Rohini. I think you can put in the chat box.
I'm like, I just want to.
Okay, Vasudendra, can I take that question about family?
Yes, sir. Yeah. You go on, sir. I will just, just
when
go
you're
through
looking through that, I will check it.
Yeah.
I think one of the things I regret most in our healthcare in this country is the lack of a family physician. I think in one of the most important institutions that we have to encourage and nurture, having trained to be a surgeon in a society which had a very strong family physician concept with the National Health Service in the UK, I have seen the advantages of having a family physician, a GP, a general practitioner. And so right now, we really are facing, I think, a very severe, a very serious situation without family physicians, because he can be an excellent medium for building the trust between patients and specialists. He spends more time with them. He's a friend, philosopher, and a doctor. And I sincerely hope and pray that we get back that system in this country.
Yeah, another question is related to that. Like somebody has put fragmentation of medicine into many branches. I mean, specialization or super specialization, which leads to ignorance of holistic medicine. So that's another question which was there.
I agree, and that is related. You're related, right. Yeah. The two are related. Yes. And but I must again say, I must add here that as a surgeon, I see many patients with an abdominal pain for 1 or 2 days. And I tell them very openly, look, this is very simple. You don't need to come to a surgical clinic for this. Try and see a family doctor. And if it persists after some basic intervention, you can always go to a specialist later. So we must educate the people to try and seek family physician help before going to specialists.
Yeah, just one question I had to you, sir. Like during your consultation with patient, you allow the attendant, the spouse to speak, or you want only patient to speak? Because there are two views about it. Yeah. Like in the art of medicine, some prefer only patient to speak their complaints. Many other prefer both. Like
I allow both. It's very easy as a listener to know who is dominant. One is dominant and the other is quiet generally. But if the attendant is dominant, I always worry a bit. I really need to hear from the patient. So while I do not ask the attendant to stop talking, I will let him talk, him or her talk, but then I come back to the patient and tell them, now you tell me what you feel, and try to get a good history.
That's if you, that is if only if you're dealing with an adult patient who can communicate.
Yes.
When you're dealing with a child, When you're dealing with an infant, a pediatric patient, you have to remember that you have to listen to the parent. So,
Point taken. I was looking at.
so this
Yeah.
question really becomes a very,
Sir,
whether it's relevant or
yeah.
not.
Yeah, Dr. P. Venkatesh wants to tell something. He has messaged us.
Please.
Sir, Dr. Venkatesh, can you go ahead? Like he's one of your old friends.
Oh, he's from the US. Yeah, very nice. Venki,
Lakshman, good morning.
good evening from my
Good
side.
evening.
Welcome. Lovely to have you, Venki. Go on.
Happy Doctor's Day to everybody. And
Same to you.
I'm so honored and privileged to hear you speak. I've been multitasking a bit. My apologies for doing that, but I get the gist of what I've heard from Dr. Lakshman for as long as I've known him, which is 50 plus years. And it is wonderful what all of you are doing, especially the talk today, the focus on relationship with patients and that informed decision making, which is being lost. And I love the way Lakshman talked about balancing the art and science of medicine, because I've always seen medicine as a sort of perfect synergy between humanism and science. And we live in a world of ambiguity. We live in ambiguity, we thrive in it. And okay, technology has clearly exposed the limitations of bedside clinical medicine, and we have to accept it. But you have to interpret it in the context of what you are looking for. And I thought Dr. Lakshman brought it out very, very well. Not that I expect anything different from him. So kudos to all of you. I'm so proud to be an alumnus of BMC, and also for all the work all of you are doing, and more so to call Lakshman my dear friend. Thank you.
Thank you. Thank you, Venki.
Thank you so much, sir. Thank you. I think.
Vasuna, I had a question.
Dr. Rohini, go on.
Yeah.
You
Good
can switch
evening,
off your.
sir. Yeah,
tell
good
me.
evening, sir. Good evening, sir.
Good evening.
It was a very pleasant conversation, and my question was that we being very junior doctors, especially when we are working in the surgical field, being residents, and as of now, we have seen that in a present day scenario, whenever we are working in an emergency department, we are quite often attacked by the patient attendants, and this is happening quite often in these days. I just want to know, being a senior surgeon, and how to handle in such situation, and how to not get lost our hopes and keep going on in that condition where still when we work 24 hours together especially in a condition like emergency department and all.
Rohini, got your point.
Yeah, Vasudha.
Yeah, we got your point. Like you are asking another art, probably. No, sir.
Yeah, I mean, there are no easy solutions, Rohini. But I would only say that we have also faced such situations. We have faced angry mobs as juniors and even as seniors. We have been garrowed and all that. But I think the idea is to not lose heart, not to lose confidence, and stick to your guns. Most of the time, it is done to put you down. But then you are a professional, so stick to your guns. Be nice to them in spite of being provoked. That is the biggest difficulty I have faced. I lose temper quite quickly, to be honest. I confess to that.
Yes,
sir. To keep a cool face when somebody is unfairly targeting you is very difficult. But you must learn that art, and I think with age that comes. But that doesn't take away the fact that all of us must be united. All the doctors concerned must be united. We should not expose each other to this kind of mob mentality. And there must be physical arrangements for safety. All said and done, even you are at physical danger, you may be beaten up and damaged. Every institution must work towards providing its health professionals physical safety. These are principles, but what happens at a given time and a given institution, we are still seeing doctors being beaten up. Very sad, but it's an ongoing process.
Thank you very much, sir. Thank you very much.
Next question is from Dr. Anu. He is one of my close friends from UK. Go ahead, Anu.
Thanks, Vasu. Can you hear me?
Yes.
Yeah, yeah,
I can.
sure.
Yeah.
Yeah, Dr. Lakshman, it was an excellent presentation from yourself and from all the participants.
Thank you.
It's not a question, it's really a comment. It might be a bit controversial. I think I thought I'll still raise it.
Please
I mean,
do.
I mean, I'm a psychiatrist and I was Vasu's classmate in Ballari. My question is, are we as doctors getting too precious and taking ourselves too seriously? The reason I'm asking that question is, as a psychiatrist, we work in a multidisciplinary team where even though I'm a consultant, I'm still almost equal to the others. But in India, I see that doctors are head and shoulders above others in terms of the support staff. Should we try and allow ourselves to take ourselves a bit less seriously? Would that make things easier? I know things are harder in India with all the media, negative coverage, etc. What are your thoughts?
I think you have raised a very important point. I don't think, honestly, there's anything controversial about it. I think it is something I endeavor to do every day. Two things. I think the hierarchy in the healthcare system must go. You know, I may be the chief of a unit, but my associate, my nurses who help me are as important as I am in running my show. Okay, and it is our show, not my show. That is something we must have, and when we bear that in mind, the team works as a cohesive unit, and things will become simpler. The second thing is, and this is a bigger challenge, our patients, whether they like it or not, whether we like it or not, sorry, our patients have huge expectations. They come and, you know, as somebody said earlier, they say, look, we think you're God. Vaidyo Narayano Harihi. You know, today is Doctor's Day. I get a lot of things saying Vaidyo Narayano Harihi. I think that thought should go away. They must look at doctors just like they look at other professionals, doing a job, trained to do a job, and we must, as doctors, be accountable. And that hierarchy where somebody is higher and somebody else is lower must go. And I agree, compared to the West, you know, I've worked both in the UK and the US, compared to the Western countries, we still have that kind of gap. And if we manage to reduce the gap, I think the misunderstanding will also reduce.
Thank you so much to both of you.
Yeah, thanks, Anu.
Thanks, Vasu.
Any other question? If not, I had one question to Dr. Lakshman, sir. Sir, like many times we see patients and we know the prognosis. But sometimes we may tell the patients that everything will be all right. Scientifically, it is not plausible. Is it ethical to assure patient in such a scenario where treatment will not help? So that is the dilemma sometimes we face, like how to handle this, to tell the truth on face or to tell in a different manner, but you tell the truth. How do you manage that?
A very good question, an ethical question, and I'm always for telling the truth. The way you say it can be in different ways, you know, and the art of communication, which is actually taught, you know, in the West, and we do it here to our residents also. There is a whole segment of the art of communicating bad news. In fact, people are examined on that. People are examined on that. Surgical resident, any resident, there is a part of the examination on that.
Yeah, how to break bad news.
How to break bad news is a part of it, and that I think everything has to learn. Everybody has to learn. But let me look at the exception first. This is the exception, not the rule. Most people that I feel will say, okay, you can square with the patient about whatever the diagnosis is. But there are a few families which happens, look, the patient doesn't know, so don't tell them. They will have a heart attack, or they have blood pressure, they have this, they have that. Don't tell them. Without taking the family into confidence, we do not break bad news to the patient. We need to have the family's concurrence for breaking bad news.
Yes.
But we tell the family two things, and in 90% of cases, within a day or two, the family will agree to your breaking the bad news. What are the two things that we tell them? A, that the patient trusts only two people in the whole game. One is the family, the son, the father, whoever, the husband, the spouse. Now, that patient has so much trust in you. And if the patient feels that you're telling him or her a lie, where is that trust gone? That is not acceptable. The second person he or she trusts is the doctor. And if the doctor is telling them a lie, what happens to that relationship? It won't be healthy. So to have a healthy relationship with the patient, I tell the attendant, please allow me to talk to them the truth. And the truth may not be told in a harsh way. It can be a very nice one. An inoperable cancer, where the patient is, we're not going to give any treatment. It is advanced, metastatic everywhere. The extreme example. All I tell them is that, look, you have this thing called cancer. But the moment I say this word, you go into a panic. You go into a panic. Please don't do. Many people do very well, even with cancers. Okay, we will give you treatment for this. And next thing I say is, absolutely, while I may not be able to cure it for you, we will be able to control it for you. That is a measured lie, because if you may not be able to, control it completely, but it is not a, it's a white lie. If you ask me, there is that that fine line in ethics.
You have to trade off.
Trade off. So we will be able to control it. And the other thing that they're going to ask you is, am I going to suffer? I tell them proactively, we have every means of controlling suffering. You will not be suffering from pain or disability. We will be able to help you and keep you comfortable. And the final question they ask is, how long do I have to live? And I tell them, I do not know. Nobody knows. And I tell them, I don't think you should even think about it. Enjoy life as it happens. And we cannot put a time on longevity. This is the kind of thing that I have always practiced while conveying information.
And it has worked for you.
It has worked for me, yes.
And probably like culture, the background, that also varies from region to region. Yeah.
Absolutely.
Yeah, then another question is, in these days of defensive medicine, how do you balance between investigations? Like you can try and solve a problem without investigations.
Yeah.
But for defensive medicine's sake, for later litigations and all.
Correct.
Like how to solve that situation?
Sadly, I've had to change for the sake of documentation. 15 years ago, I was practicing practically clinical medicine. I was quite sure somebody didn't have a bad disease or something else. Non-ulcer dyspepsia is a very common diagnosis in my field. They keep coming saying, I have acidity, I have this, I have that. And I would not do an endoscopy. We have what are called danger symptoms. I would ask for it. If the danger symptoms were not there, I would not do an endoscopy. But sadly, in the last 15 years, with so many, that's why I talked about the responsibility of society and judiciary. I covered it in my talk.
Okay.
It has happened such a way that there have been cases where the doctor has been hauled up for not doing tests. And so what I do now is tell the patient and document it in my outpatients. Look, I do not think it is dangerous. I would not primarily recommend a test, but if you want it, I will do it. That is the modification I have made. And many people say I want it. They will not say I don't want it. So I do it. But in the few people who says, okay, I'll wait and see, you can always wait 2, 3, 4 weeks before symptoms go away. And so my initial recommendation is that I would have done the clinical examination. I do not think there is anything dangerous. Take this medication, come back in 3 weeks or 2 weeks. If they agree, that is fine. If they don't agree, and if I find that they are sort of vacillating between acceptance and investigations, I err on the side of investigations for the sake of documentation.
Yes, sir. I think any other questions from audience? Some have commented about the crumbling public health system. That is one of the problems. And patient counseling is very important part in treatment. But only few doctors are doing it. That is one of the comments I saw there. Then most of them have said like it was a wonderful session.
Thank you.
Many topics were covered, and discussion is also going on well. And yes, sir, that's it. And if anyone wants to ask question, I think, sir, you have another 10-15 minutes time. It's almost 7:20. Yeah.
I mean, if I have another 10 minutes. It's nice to have multiple sessions than one long session.
So, that's true. Any participant, if you have any, Dr. Dharmanand, I think you can speak, sir. And I have few people who have sent their names beforehand only. I can read them.
I really welcome that. I would like other people to give their views as well. It will be a learning for me as well. Yeah, that will be very nice. Yeah.
Yeah, Dr. Dharmanand sir, are you listening?
Yes, yes, I am listening.
Yeah, yeah. You had one. You asked one question. If you have any comment to make or ask a question, you can.
I had few comments. I think as a society, we reflect the society as a doctors. So doctors are the ones who take the blame all the time. But I think from the childhood we are corrupted from school education. So it's pretty difficult for a doctor to be always above board all the time. So that is a reality. So though it is not ideal, that is the reality I feel. And with regards to clinical medicine, as far as possible, you have to communicate your concerns. And if the patients are brainwashed to look for investigations, I think we have to do it. Because if by any chance, if they are right, in even if it is 1%, then they will always say that I insisted. The doctors refused to do a X-ray. So that will be a big issue. Big issue.
So has technology substituted clinical this thing?
No way. And people come with problem is the current doctors face is patients come with all the reports. If I ask for 10 tests, Thyrocare does 200 tests. It is for me to interpret so many tests which I am not competent to interpret. So that becomes a big problem. If I ask for a back scan, they get an entire cervical span to sacrum scan. And they have a small bulge there, they want me to interpret. So it becomes a little more complicated. So doctors are not the only one to blame. End of the day, it is the conglomeration of the lab, the marketing of the lab test directly to the patients. And that also forms an important thing. Of course, Dr. Google also contributes a lot.
Okay, sir. Yeah. And Dr. Babu, he said like, don't ever assure about percentages. Don't speak about percentages. That is one tip he has suggested. I think he's a senior plastic surgeon. And we have few other doctors. Dr. Murali Mohan, if he is there, he can make his comments or question. Dr. Venkatraman, Dr. Shankar, Dr. Asha Benkappa. If anyone of you sirs are there, can make comments. Dr. Babu sir, you can speak. And there is one more question: how to stop corruption in medical practice?
Yeah, very big topic. Maybe we should have a group discussion on this rather than me saying something about it. Maybe we should arrange a group discussion sometime.
Sure. And I didn't listen your total complete topic. Like any books you suggest on this topic, apart from Osler. I heard Fisherisms or Peabody.
Most of the reading I've done is from the net. I haven't read a textbook per se, but there's a lot of material on this. And interested people can just go onto the net and they'll get very good information. Particularly about defensive medicine, there is a lot of very solid data about it. And I would recommend that people read it, because when they ask for tests, it can tell them how misleading it can be. The intentions are very good, but the consequences can be significant. So I would definitely read up about defensive medicine.
Okay. If Dr. Sudha is there, she can also make any comments.
Hello.
Yeah. Yes. Go ahead, madam.
I just wanted to make a point, particularly for students. If they develop that clinical acumen, it develops as an instinct. That I feel in the earlier formative days, it's very important. Examination of the patient, that acumen develops, then investigation will only be helpful. So if some investigation doesn't match the clinical finding, you are put on the alert. Otherwise, if you just go by the investigations, you can definitely land up into trouble. I feel that they should develop that instinct and clinical acumen. That much.
Very true. The point you made about the lack of correlation between clinical findings and investigations is very important. In fact, when my students or my patients keep showing me the investigations, I tell them, I'm treating you, I'm treating the patient, I'm not treating the paper. You know, it's one of my common statements. And it's very true that all I'm saying is that looking at the totality of the scenario, we need to make choices about how we should progress and not look at one parameter that a lab throws up. Very important point.
And one more question is regarding telemedicine. Nowadays, which has gained because of lockdown and all. How do you view it? Like, is it the new normal? It is going to stay? And how do you manage?
Yeah. Telemedicine is here to stay, but it cannot replace the face-to-face consultation. It has tremendous value, as I said, when there is a pandemic like this. So where physical contact is dangerous, but it cannot be the be-all and end-all of healthcare. It is a very good screening tool. And another area where even when you don't have a pandemic, where telemedicine is useful, is to save money and effort to the patient for follow-ups. You have seen the patient first, treated him, you know who the patient is, what his trends are, and he need not travel 200 kilometers to come and do a one clinic visit for you, or even 10 kilometers from a very crowded other end of Bangalore, for example. So for kind of follow-up, once you know the person, I think telemedicine is helpful, but it cannot replace the conventional face-to-face contact.
We are using extensively telemedicine for follow-up patients. It's
Yes.
extremely useful.
Yes.
All our immunosuppressed patients who cannot come out during this period.
Correct.
So we've been able to see 10 to 15 patients a day conveniently, make some adjustments. That has been found but
no, sir.
new patient is always difficult.
No. How are you making? Like, you're seeing pictures, making videos, and then commenting, or only like how are you doing exactly?
Hospital is connecting through. There are two methods hospital connect. One is through they can give a Zoom link and we can contact, and they can generate a prescription and I can type a prescription. But most of the patients are not able to do that. So we are also doing a WhatsApp-based teleconference thing. So there is a secretary sitting in the hospital who transmits all the investigations to me. I go through the investigations and then dictate to an assistant. He will write a prescription and send it to the patient, and after showing it to me. Because I am stuck at home, quarantine, so I can't go to the hospital. I don't have a prescription.
Yeah, but at least it was helpful, like for the patients. And actually, to be honest, we are very happy that it crossed 100 today, and many of our friends could not join.
Yes, some of my friends couldn't join.
Yes, sir. Yes, sir.
So I will put a recording of this on YouTube. Unfortunately, the live program, somehow there was a technical hitch, but I will put a recording by tomorrow on YouTube. I can send you a link, and all of you can share it with people who are interested in listening to this. Unfortunately, it could not be live.
Yeah, no problem, no sir. Actually, we were flooded with messages. In between, my link got cut and I could not enter.
Yeah.
Anyway, and coming to next questions. Dr. Anup, again, like he has mentioned, we should give equal importance to physical and mental health in India, and there is evidence that both are intertwined. How is it? Could you throw light on that? So I think it is right.
Yeah, we agree with that. We try to do that, but I must say, as a surgeon, I have honestly very little insight into the emotional health, and so I'm trying to learn and see what I can do. My emotional support to the patient, I think, is bordering on a layman's support rather than a professional support. I concede that, but if I find that things are going a little out of control where I cannot help the patient, I do suggest counseling so that they can help themselves with a professional.
Right. Yes, sir. That's it. I think if anybody wants to raise hands or ask questions, I think we are almost.
I think we are fine. I think we've had a very nice discussion. Sorry, Rohini. She wants to talk again.
Yeah, I wanted to tell something.
Yeah, please.
Actually, the session was really very good. Probably the session was like it was very good for the junior doctors who are like just practicing, and then they need some like medical ethics and all. What today the session was there, it was really very educative. Like when we are in the starting process of our profession, and then knowing it all, it was really very educative. And I would like to thank Dr. Lakshman sir for giving such a nice presentation. So we would like to hear from you in near future also. You'd be really an inspiration for our junior surgeons who are going to pursue further.
Thank you very much, Rohini.
And it's indeed, and such sessions are needed when we meet all the senior doctors at the same platform, where we don't get that space where we can express ourselves, except from profession like ethics and all is usually not discussed in our workplaces, which is much needed. I feel whenever we are practicing, it's much needed, like how to make an decision between like when you how to go upon the tests, and whether we have to go for surgeries, and after when surgery, even after performing surgery, if it is a failure, then how to attend to that. And many a times when we are always told that we doctors are all trying to make money more than
I think we got
we will do that, Rohini. We will have sessions. Okay,
we'll have sessions. I think we can have short sessions on subtopics. I think this is a huge topic, and we can make cut topics and do once again. Anyway, I think we have come to the end of this wonderful discussion. There were some technical problems in the beginning. Many, I think nearly 40 were waiting for YouTube link, and we are sorry for that. Please convey to your friends. Despite of we trying our best, we couldn't do. As Dr. Lakshman sir told, we will definitely upload the video and send you the link. You can definitely see there. And as far as the topic is concerned, I think sir has covered wonderfully, and many of you, our senior doctors and juniors, they have contributed to this discussion, wonderful discussion. And I think we should have more of art to our clinical practice, in addition to the science of medical practice. And what I hear in my short practice, more of art is very much needed on the solid foundation, of course, on science and humanism. So both should go hand in hand, and doctor's role is definitely more. Many say paternalistic attitude is required in practice, but it should be both, like patients to have rights, and we should respect sentiments of the patient. So anyway, with these few words, I thank Dr. Shivkumar, who introduced and participated in conducting this program, and we thank all our participants. MSc thanks wholeheartedly Dr. Lakshman sir, who was extremely cooperative to use a subscription for this live webinar and discussion. Thank you so much, sir.
Thank you very much, MSc, and all the participants for joining in this lovely discussion. I found it very, very helpful to myself. I found it very enjoyable, and thank you very much once again.
And before signing off, I recommend 2 books. One is Forgotten Art of Healing by Dr. Farooq Udwadia. I think he's intensivist in Breach County Hospital. That is one of the best books I read. And another is Dr. Laun. He is a cardiologist in US. So both books for juniors, they can go through. He has covered a lot of examples and all. And of course, Dr. Lakshman sir will be there, and we can have frequent discussions on this topic. So with this, we conclude. Thank you once again, all of you.
Good evening and goodbye.
Good evening. Yeah, good night, sir.